Thank you. So I would like to thank the organizers of the Congress for inviting me to come over and speak to you today about Horner syndrome. And we're going to review the anatomy of the ocular sympathetic pathway, learn to localize lesions based on clinical findings, and then become familiar with some of the lesions that we can commonly encounter along the course of the ocular sympathetic pathway. Now, Horner syndrome occurs when there's interruption of the ocular sympathetic pathway, and the clinical symptoms may cause little, if any, functional impairment in most patients. However, since both benign and malignant disease processes are associated with Horner syndrome, a thorough clinical examination is required. This anatomic pathway consists of 3 neurons, the first-order neurons, which are found in the posterior lateral hypothalamus, the second-order neurons, which are found in the ciliary spinal center at around C8 to T2, and the third-order neuron, which is found in the superior cervical ganglion. Now let's see how the ocular sympathetic fibers travel from the hypothalamus to the eye. So we begin in the first-order neuron in the posterior lateral hypothalamus. The postganglionic fibers descend in the reticular formation through the brainstem, cervical, and thoracic cord to synapse in the intermediate lateral gray substance at the level of C8 to T2. The second-order neuron postganglionic fibers exit in the ventral spinal roots and pass through the inferior, middle, and middle cervical ganglions before they synapse with the third-order neuron in the superior cervical ganglion. The postganglionic fibers of the third-order neuron travel with the internal and external carotid arteries. Those that travel with the internal carotid follow the internal carotid artery, then they go on to the 6th cranial nerve, then to V1, and then go on to innervate the mular muscles of the upper and lower eyelids, as well as the dilator muscles of the iris. The fibers that travel with the external carotid go to the face and are responsible for sweating in this area. The ocular sympathetic innervation is ipsilateral to the sweat glands of the body and face, to the dilator muscles of the iris, and the retractor muscles of the eyelid, so thus to the upper and lower mular muscles. And when we think in terms of the clinical findings that we see in patients with Horner syndrome, most of us are familiar with the classic triad of ptosis, meiosis, and anhidrosis. But it's probably worthwhile to spend a little bit of time looking at the etiology of these findings. So let's look first at ptosis. So we have Mueller's muscle, which is this small, thin muscle, smooth muscle that's found on the undersurface of the levator palpebrae superioris muscle. And this muscle elevates the upper eyelid and controls the resting position of the upper eyelid when the eye is open. And it's innervated by the sympathetic nervous system. So when you have an interruption to the sympathetic supply, this results in the drooping of the upper eyelid, which is referred to as a ptosis. Meiosis is a decrease in pupil size due to paralysis of the dilator muscle. So the sphincter and dilator muscles of the iris are innervated by the autonomic nervous system. The sympathetic system innervates the sphincter muscle, and the parasympathetics innervate the dilator muscles. So when you have the sympathetic innervation is interrupted, the parasympathetic innervation of the sphincter muscle is unopposed, and therefore you will have the pupil constricting, as we see here in this patient. Anhidrosis is a lack of sweat production due to interruption of the sympathetic innervation of the sweat glands. And if you have an absence of sweat on the forehead, the face, or the body on one side, it's usually a good indication that the patient has a Horner syndrome. However, I will say that this is one of the clinical findings that may be very difficult for you to elicit on physical examination. Some of the other clinical findings that we can see are conjunctival hyperemia, upside-down ptosis, iris heterochromia, and the harlequin sign. So the early transient finding of acute Horner syndrome is conjunctival hyperemia. So the sympathetic denervation causes vasodilatation of the capillaries and the conjunctiva, and then the patients will have what appears to be bloodshot eyes. The upside-down ptosis is, again, best appreciated when the upper eyelid is in the resting position, and the sympathetic fibers also innervate the retractor muscles in the mular muscle in the lower eyelid. So what happens when the sympathetic innervation is interrupted? You get an elevation of the lower eyelid, a drooping of the upper eyelid, and a narrowing of the palpebral fissure, which gives you the impression that the patient, it makes it look as if the patient has an ophthalmos. Now, iris heterochromia is also important to be familiar with. The iris is blue or gray at birth, and an intact ocular sympathetic pathway is required for pigmentation of the iris to develop in the first year of life. So if you have a lesion that causes interruption of the ocular sympathetic pathway in the first year of life, it will lead to a light-colored iris, as we see in this patient who also has the other clinical findings, the miosis and ptosis of both the upper and lower eyelids in this patient with a congenital Horner syndrome. The Harlequin sign has also been described in children with the congenital Horner syndrome, where they have a unilateral facial flushing. And we see in this the areas that do not flush correspond to the areas where they have anhidrosis. They also have a decreased skin temperature on the affected side, and this is due to impaired vasodilatation. So now, how do we classify Horner syndrome? We can classify it as preganglionic and postganglionic. So the preganglionic Horner syndrome are caused by lesions that occur proximal to the superior cervical ganglion. And the postganglionic Horner syndrome are caused by lesions that occur anywhere from the superior cervical ganglion to the eye. The preganglionic Horner syndrome can be further subdivided as calling them central or first-order neuron or peripheral or second-order neuron Horner syndrome. So the central ones are the ones that go from the hypothalamus, and it can involve all the postganglionic fibers before they synapse in the second-order neuron. And then the peripheral or second-order neuron Horner syndrome, those are caused by lesions that occur in the second-order neuron or in its postganglionic fibers before they synapse with the third-order neuron in the superior cervical ganglion. Postganglionic Horner syndrome, also referred to as a third-order neuron Horner syndrome, is caused by lesions that occur anywhere from the superior cervical ganglion to the eye. So now, what about the clinical evaluation? You have a patient, the patient comes in, and the patient has anisocoria. That is, that the pupils are unequal. Now, this may be due to a number of causes. It can be due to aging, sympathetic or parasympathetic dysfunction. And an examination in the dark will help you to determine the etiology. So the main thing that we are asking ourselves is the pupil inequality greater in the dark or in the light? And the point is that the sympathetic denervated pupil dilates slower than the normal pupil in the dark. So the best way to evaluate this is to take photographs at 5 and 15 seconds in the dark. So we have a patient that comes in with unequal pupils. So in the dark, if there's no dilation lag, then this is just a physiologic anisocoria, and there's nothing for us to do with this patient. If there is dilation lag, then this indicates that there's a sympathetic lesion, and you can go on to do pharmacological testing to confirm the diagnosis. If the inequality in the pupil is greater in the light, this indicates that you have a parasympathetic lesion, a lesion that's interrupting the parasympathetic supply. So ideally, when we're doing pharmacological testing, they like to do sequential testing using cocaine and hydroxyamphetamine. And they should be done first by doing the cocaine instillation. Then you wait anywhere from 24 to 72 hours afterwards to put in the hydroxyamphetamine. A poor response to cocaine confirms the diagnosis of Horner syndrome, and depending on the response to hydroxyamphetamine, this will help you to determine if the Horner's is pre or post ganglionic. So if the sympathetic pathway is intact, norepinephrine is released from the nerves innervating the dilator muscles. And as you can see here, even on the normal side, the pupil will dilate when you put the cocaine in. But on the side where the patient has the Horner syndrome, it dilates as well, and there's also some elevation of the eyelid on that side. So the normal pupil dilates. The Horner's pupil also dilates, but has a much poorer response. And you also, again, as I said, have some elevation of the eyelid associated with that as well. Hydroxyamphetamine releases norepinephrine from the postganglionic nerve endings to the dilator muscles. So in patients with preganglionic Horner syndrome, that is first and second order neuron Horner syndrome, you'll see that the pupil dilates. But in patients with the postganglionic Horner syndrome, the pupil does not dilate because the norepinephrine is depleted from the nerve endings. And as I mentioned before, you start the evaluation with the cocaine. And then what you do is you wait 24 to 72 hours to ensure maximum response to hydroxyamphetamine, and then you can proceed with the examination. So let's look now at some lesions all along the course of the oculosympathetic pathway. So the first ones we're going to look at are the first-order neuron Horner syndrome, or the central preganglionic Horner syndrome. And again, these are the lesions that occur anywhere from the hypothalamus down along the postganglionic fibers before they synapse with the second-order neuron. And this is the least common location for the preganglionic Horner syndrome. These patients, meiosis may be the only evidence of Horner syndrome in these patients. Usually they'll present with cerebellar or brainstem symptoms, and if they have anhidrosis, it's to the ipsilateral half of the body. And again, you see the eye findings that after the cocaine, the pupil dilates, and with the hydroxyamphetamine, the pupil will dilate even more. So the etiologies: brainstem infarcts, tumors of the hypothalamus, brainstem, or spinal cord, trauma, infection, syringomyelia, and demyelinating disease. So how do you image the patient? It's going to depend on the clinical findings. So obviously, if you've evaluated the patient clinically and you feel that the patient has a Horner syndrome likely in the first-order neuron distribution, and they have brain or brainstem findings, then you're going to do an MR, or MR with or without an MRA. And if you think that it's due to ischemia, you can do diffusion-weighted imaging. If there are myelopathic findings, then you know that the pathology is going to be found somewhere in the cervical or upper thoracic spine, and that's the area that should be evaluated. So the most common cause of first-order neuron Horner syndrome is the lateral medullary plate syndrome, or Wallenberg syndrome, and it can be caused by the occlusion of pica, or the vertebral artery, that produces an infarct in this region, in the area where the sympathetic fibers are traveling. And here, this area that I have shaded in purple is where the infarct is, and that corresponds with the abnormality noted on the MR in this patient. Now, these patients can have a number of other cranial nerve palsies as well as tract findings as well. So Horner syndrome is not going to be the only thing that you're going to see on clinical examination. This is a 13-year-old boy with headaches and left anisocoria, and with pharmacological testing, they said that he had a left preganglionic Horner syndrome, so that in conjunction with the clinical findings would lead one to go on and do the MR of the brain first, and here we see the cystic lesion in the posterior lateral aspect of the hypothalamus, which was a pilocytic astrocytoma that was causing this patient's Horner syndrome. Syringomyelia, intramedullary cysts that contain CSF, can cause compression of the gray and white matter in the cord. And the interesting thing about this disease is that the Horner syndrome may actually alternate from eye to eye. So one day it may be on one side, the next day may be on the other side. So when you see an alternating Horner syndrome, this is what you should consider. The presence of Horner syndrome in patients with demyelinating disease, such as MS, suggests the possibility of cord involvement. And the MS plaques tend to occur on the dorsal lateral aspect of the cord, and this is where the sympathetic fibers are traveling in the cord. So here's a patient with MS. We can see the area where the plaque is located on the dorsal lateral aspect of the cord, explaining why this patient has a Horner syndrome. So let's look now at the second-order neuron Horner syndrome, or the peripheral preganglionic Horner syndrome. And again, the lesions, these lesions can occur anywhere from the second-order neuron itself to before where its postganglionic fibers synapse in the third-order neuron. And the majority of the preganglionic Horner syndromes occur in this distribution, in this location. And the clinical findings, they're going to have the full syndrome of ptosis, meiosis, and anhidrosis. The anhidrosis is ipsilateral to the face and neck, and sometimes these patients may have a brachial plexopathy as well. The etiologies are quite vast. They can be secondary to surgery or trauma of the thorax and neck, Pancoast tumors, primary spinal nerve root tumors or lesions that are causing compression or destruction of the nerve root, sympathetic chain lesions, or masses in the neck which are strategically placed where they're causing compression of the cervical sympathetic chain. And again, when you think in terms of imaging in this category, you have to remember that the lesions can be found either in the spine itself, in the second-order neuron, in the nerve roots from C8 to T2, or in the neck, going anywhere from the base of the neck up to C2, C3. And again, we'll see how the Pancoast tumors involve this area as well. So if the patient has a mass in the neck on physical examination, or you see a mass in the lung apex on a chest x-ray, I usually tend to just do a CT to cover the area of interest. If, however, there are clinical findings to suggest that the spine or nerve roots are involved, then I would do an MR. So otherwise, you'd have to cover the entire area of the lower portion of the spine and then do the neck up to C2, C3. The Pancoast tumors are the lesions that we're most familiar with, extending in from the superior sulcus up into the root of the neck, and these are usually non-small cell bronchogenic tumors, either squamous or adeno variety. And these lesions can cause a second-order neuron Horner syndrome because they can involve the inferior cervical ganglion, and they can also go on to involve the brachial plexus, so these patients may have a brachial plexopathy as well. Usually, they're involving primarily the inferior trunk of the brachial plexus. So let's look at the relationship of the brachial plexus to the sympathetic ganglion. So here we can see the inferior trunk of the brachial plexus formed by the C8 and T1 nerve roots. And if you look between those nerve roots, you can see here the inferior cervical ganglion. Remember, sometimes this ganglion is very large. When you have a fusion of the inferior cervical and first thoracic ganglion, it's referred to as the stellate ganglion. So on the coronal MR, the C8 nerve root, here's the ganglion here, and it's easy to understand why when this lesion actually extends up into the root of the neck, it's going to pinch off these nerves right here. So this is exactly what happened in this patient. He's 58 years old. He had weight loss, right brachial plexopathy, and a preganglionic Horner syndrome. And you can see there's a lesion in the lung apex, but you'll also see that there's marked asymmetry in the soft tissues of the neck. So it's extending up into the soft tissues of the neck as well. On the CT scan, I can see the vertebral artery on the left. Directly posterior to the vertebral artery, this arrow should be pointing to this, is the inferior cervical ganglion. And on the opposite side, the vertebral artery, we see that the tumor extends posterior to the vertebral artery all the way over to the spine. So you would have, if you had to guess, you'd say that this person likely has involvement of the inferior cervical ganglion. You see that the lesion also is extending posterior to the subclavian artery, and we know that directly posterior to the subclavian artery is what? The inferior trunk of the brachial plexus in this area right here. And the lesion is also engulfing the scalene muscles, and that's the area between the anterior and middle scalene where the cervical nerve roots are coming out that form the brachial plexus. This is a 19-year-old with a preganglionic Horner syndrome on the right, and we see that this mass has a nice smooth interface with the lung parenchyma on both the axial and the coronal image, telling us that the lesion is likely located outside of the lung itself. And then if we look here, we can actually see the inferior cervical ganglion. So this was a schwannoma arising from the inferior cervical ganglion. The cervical sympathetic chain runs longitudinally over the longus colli and capitis muscles, and it's found posterior medial to the carotid sheath, deep to the prevertebral fascia. So lesions, when they involve the cervical sympathetic chain, typically cause anterior and anterior lateral displacement of the carotid sheath structures. Nerve sheath tumors can arise in the sympathetic chain, and Horner syndrome may be part of the initial presentation, but more often than not, the Horner syndrome occurs after the patient has had surgery to have the lesion removed. So these are two sympathetic chain schwannomas, one in the infrahyoid neck, as we see here on the imaging sequences, causing anterolateral displacement of the carotid sheath structures, and you see that the lesion is actually pressing on the prevertebral muscles here, right in the area where the sympathetic chain is located. In the suprahyoid neck, similar signal intensity that we see in the lesion. The carotid vessels are displaced anteriorly. The internal jugular vein is displaced laterally and somewhat splayed, but again, it's the location of the lesion and the pattern of displacement that enables you to provide the reasonable differential diagnosis that this lesion is arising from the sympathetic chain. The neuroblastomas arise from the neural crest cells in the adrenal gland and cervical sympathetic chain, with less than 5% of these lesions located in the neck. And these lesions should be looked for in children who present with a Horner syndrome, iris heterochromia, and no history of cervical trauma, which was the case in this 2-year-old male with a right preganglionic Horner syndrome. It's an old case. So on the proton density image here, we can see the lesion has somewhat of a heterogeneous appearance. And again, look at that interface between the lesion and the lung parenchyma, nice and smooth, telling me again that the lesion probably is not coming from the lung but outside. The lesion enhances, and then you can also see the inferior cervical ganglion on the opposite side. So right in the right location for a lesion arising from the inferior cervical ganglion. Any lesion that compresses the sympathetic chain can produce a Horner syndrome, and that was the case in this 50-year-old female with breast cancer who had a preganglionic Horner syndrome. Here's a mass, and you can see that that mass is engulfing the prevertebral muscles right in the area where the sympathetic chain is located. This sometimes you'll see with goiters or large thyroid lesions, as in this patient, you'll see that the left lobe of the thyroid extends all the way posterior and is actually abutting the anterior aspect of that muscle, and it's actually compressing the sympathetic chain, and that's why this patient has a Horner syndrome. So when you think in terms of thyroid lesions, sometimes you'll have patients with thyroid lesions and a Horner syndrome. It's rare, but when it does occur, it's usually secondary to benign disease, and that's not the case when you think in terms of somebody with a vocal cord paralysis and a thyroid lesion. In those cases, the thyroid lesion should be considered malignant until proven otherwise. So let's move now to the third order neuron Horner syndrome, or the post-ganglionic Horner syndrome. And again, these are lesions that occur anywhere from the superior cervical ganglion to the eye. So this is the third order neuron. And the full syndrome can be seen with these patients too: ptosis, meiosis, and anhidrosis. Sometimes there are other clinical findings that may help you localize the lesion. The orbital lesions, sometimes these patients will have proptosis, chemosis, and conjunctival hyperemia. Those involving the cavernous sinus, if they're involving the sympathetics in that region. The patients may have ipsilateral extraocular paresis, and especially if the sixth nerve is involved without brainstem findings, you should think of the cavernous sinus. Carotid dissections, a history of trauma, neck pain, ipsilateral vision loss, and acute onset of post-ganglionic Horner syndrome. The anhidrosis, it may help you determine where the lesion is located. If it's anhidrosis is ipsilateral to the face and neck, that means the lesion is in the ganglion. But if it's distal to the ganglion, the anhidrosis will just be to the nose and forehead in this region. And again, the eye findings, you're going to see that the pupil dilates after the administration of cocaine, but it does not dilate after the administration of hydroxyamphetamine. So that's how you can differentiate between the pre- and post-ganglionic Horner syndrome. So let's just look at that anhidrosis again. If the lesion is in the ganglion, you've knocked out all of the sympathetic fibers to the face and neck on that side. If the lesion is distal to the ganglion, you have to remember that the sympathetic fibers that supply the forehead and nose travel with the internal carotid on that side. So we've already alluded to a number of the etiologies: carotid dissection, sometimes fibromuscular dysplasia. Keep in mind that a cluster of migraine headaches are associated with transient Horner syndrome as well. And this is sometimes seen in the emergency room setting. Trauma, neoplasms or infections involving the orbit, pericarotid, and cavernous sinus regions can also cause a third-order neuron Horner syndrome. Now, if you talk to the neuro-ophthalmologist, some of them will say when they have a lesion in this distribution, if they have no localizing findings, some of them will not bother to image the patients at all. But if you have focal findings, then you would scan the area that you suspect the lesion to be located in. And then obviously, if there's anything that suggests that the patient has a carotid dissection, you can do whichever study you prefer. I think most people actually do MR nowadays. So here's a patient with fibromuscular dysplasia, a characteristic appearance. And you might say, well, why would this patient have a Horner syndrome? Well, you can see that the artery is dilated. And then you can see here, this is the cervical plexus traveling. It travels actually in the adventitia of the carotid. So with the artery dilating, it causes compression of the sympathetic fibers. Sort of the same thing you would see in somebody with a carotid dissection, because here you can see the area where the hematoma is, and you have the eccentric flow void in this patient with a carotid dissection. And again, that hematoma is going to cause compression of those sympathetic fibers. Again, patients with nasopharyngeal carcinoma. Sometimes the nasopharyngeal carcinomas may come up, and you can see in this patient, there's sort of, the tumor is abutting the carotid artery, so it's probably compressing the sympathetic fibers, and that's why this patient had a third-order neuron Horner syndrome. This is a little bit of an unusual patient. It's a 5-year-old immunocompromised male who presented with left proptosis, chemosis, and conjunctival hyperemia, and a left postganglionic Horner syndrome. And here we can sort of see that there's this mass in the region of the apex of the orbit. There's the proptosis. He has some involvement of the sinuses, and this patient had invasive aspergillosis as the cause for his Horner syndrome. So when you think about Horner syndrome, and I would usually say to people before this lecture, what lesion would you have listed as a potential cause of Horner syndrome? And when you're talking to a radiologist, that may depend on what your subspecialty is. Because I think the chest radiologist, first they're going to say it's a Pancoast tumor. They might not know much beyond that. The pediatric radiologist is going to say birth trauma or neuroblastoma. And then the neuroradiologist probably would offer on the top of their list a lateral medullary plate infarct and carotid dissection. But I think now that you've heard this lecture, you know that there is more to Horner syndrome than meets the eye. So I'm going to stop there on time. Thank you.